Well, we're going to introduce our first speaker, who is, well, not first, third speaker, Associate Professor Peter Richmond. He is also a paediatric immunologist working at the University of Western Australia, Perth Children's Hospital, and Telethon Kids Institute. Welcome, Peter.
Thank you. And thanks, Shauna, for the kind introduction. And thanks, Kelly, for a fantastic welcome to country as well. I'm very passionate that we have to do our utmost in the immunisation space to decrease the burden on Aboriginal children in Western Australia and across Australia. And I also acknowledge all the wonderful Aboriginal people in this room who are doing great work. So I'm going to talk to you today about RSV. And I think as a paediatrician, it's probably been the most exciting about a new opportunity to prevent a major burden of disease that is our annual winter workload, where everyone gets stressed, hospitals get full, parents get grumpy, and kids get sick. And now we can do something about it. Yes, I'd like to acknowledge the country. I've got a lot of conflicts of interest. I've been working in the RSV field for almost 25 years, but my main conflict of interest is actually being a paediatrician who looks after these kids. And my first ever job 30 years ago was working in the infants ward at Princess Margaret Hospital. And there we had 20 beds, and in winter it was full of babies, generally under 6 months, their head stuck in a head box in those days, a big plastic box getting oxygen. We couldn't actually monitor it. We didn't have routine oximetry, and mums crying next to the babies that are also crying. And I was the only doctor on that ward. So I was heavily exposed to the burden of RSV. And so I think if we can do something about it, then I'm very keen to advocate for that. So this is an outline of my talk today. I'm actually going to mostly focus on infants and what we can do about prevent it. I will mention RSV in older adults, which is important, and we do have vaccines that are coming. But I think maybe that might be a longer talk for next year. So I think everyone has heard of RSV in this room, I hope. Not all parents have, though, and that's important. And that's partly because we traditionally haven't tested for it. In fact, Princess Margaret Hospital and PCH is probably one of the only children's hospitals in Australia that has consistently tested for RSV ever since 30 years ago when I started on that ward. And I got introduced to it by a virologist who was giving me the details of how to take a nasal swab. And the important things to recognise is that it's easily transmitted. There's an incubation period of about 3 to 4 days, and the vast majority of young infants actually get infected by their older siblings. But increasingly, actually, we're recognising adults also can get RSV, get a sore throat, can be quite unwell, and with the onset of multiplex testing, we're getting a much better picture of what that looks like. But almost everyone gets infected by 2 years of age, and about 1 in 4 of those children will develop a lower respiratory infection, a chest infection, bronchiolitis, or pneumonia. But it's also, if you have RSV as a young baby, almost certainly also to have otitis media, although we don't always look for it. And secondary bacterial infections are very common, particularly with pneumococcus, and so often is the antecedent for pneumococcal disease. And one of the things that we've learned from the pandemic when we've had these out-of-season RSV epidemics is actually how closely that aligns with presentations with pneumonia and also invasive pneumococcal disease. And because of this, about 1 in 10 infants will see their GP or the emergency department doctors because of RSV in their first year. So this is something that is affecting almost all families that we look after. Globally, there's almost 4 million deaths, 4 million hospitalisations a year, and several 100,000 deaths. These are predominantly in low and middle income countries because of lack of access to healthcare and antibiotics. In Australia, we have more than 11,000 hospitalisations each year in children under 1. And as I said, it's actually the RSV epidemic generally coincides with the winter bed block, even if we don't have influenza. And now that we have influenza and COVID, it's even more significant and creates also an impact for general practitioners as well. Overall, it's estimated somewhere about 1 in 53 babies will be admitted to hospital with RSV who are otherwise healthy. And if you're high risk, you have much higher rates of hospitalisation if you get the infection, and you're more likely to end up in ICU or requiring ventilation. And these are children who are born very premature, or those who have chronic lung or heart disease, or immunocompromised, or as also Aboriginal children are much more likely to be admitted to hospital and have a complicated illness. And this is demonstrated in this slide here. So this is from some work from data linkage led by Hannah Moore, who has been looking at risk factors for RSV hospitalisation. And you can see here there's two things that I want to show you. Clearly that it's 0 to 6 months, which is the highest risk of hospitalisation. And you can see here that for Aboriginal children, it's almost 2.5 times. So this is the rate per 1,000 infants. So this is almost 1 in 20 Aboriginal children getting hospitalised for RSV infection. It decreases in the second 6 months of year, but RSV actually remains the most common cause of pneumonia in children up to 2 years of age. And we also understand that, unfortunately, sometimes because the original diagnostic test for RSV might be done as in the community, we probably underestimate overall the hospitalisations attributable to RSV by about 30% from these same data linkage studies where we've looked at linking up PathWest data. It doesn't always get on the hospitalisation discharge code. And clearly, timing is important. So if you're under 6 months during that RSV season, you're much more likely to get hospitalised. And this is illustrated in this figure at the bottom, showing that babies born in September are much less likely to get hospitalised with RSV. Now, that's the tail end of the RSV season, but for the first month, they still have some maternal antibodies that protect them and reduce their risk of hospitalisation. You can see here, though, with these other groups of increasing prematurity, that those children are much more likely to get hospitalised as well. So clearly, they're the highest risk group. And we have had palivizumab, a monoclonal antibody, for almost 20 years, very expensive, but is required to be given as 5 injections over the winter period. So the use of it in Western Australia has been highly restricted, with only about 30 babies a year being ending up getting that. But I think one of the important things I really want to make, and this is sometimes lost in the discussion, is that of those children who are hospitalised, even though all of these other risk groups are much more likely to be hospitalised, it's still almost 85% of hospitalisations are in otherwise healthy infants. So if we really want to make an impact on this disease, we have to have a universal program. There are a couple of examples of that are now being rolled out. But it's not only that. Because if you get hospitalised with RSV, you're much more likely to be re-hospitalised with viral-induced wheeze in subsequent years. So the children, we used to call it asthma, we now call it viral-induced wheeze in preschool children. And it's a bit of a chicken and egg, and it's probably a combination of babies already being vulnerable who are going to be hospitalised, so they may have sort of some mild reductions in their lung capacity, which means they're more likely to get severe illness. But there's also probably a secondary inflammation that occurs as part of that. And again, we know if you are colonised with bacteria in the nasopharynx, you're more likely to develop persistent bacterial bronchitis after you have a RSV lower respiratory infection in that first year of life. And this is particularly an issue for Aboriginal children. So they're more likely to go on and develop recurrent chest infections as well, and in some cases even bronchiectasis. And it's the same for ear infections. And so some of the studies have actually been able to demonstrate an impact on reduction in antibiotic scripts because of this. And so I think we have all been aware this is a fairly typical RSV season, a sort of a lower season that occurred prior to the pandemic, so starting in May and ending in September. The green line is children and the line underneath it is adults. And you can see the increasing testing in adults so that it more mirrors the paediatric hospitalisations. And you can see here that during the pandemic, during that lockdown, we had a complete absence of RSV for winter. And then just as I went on holiday for Christmas, we had this major out of season epidemic that was the highest incidence that we've ever documented within that very limited 8-week period. So it was a very short, sharp pandemic. And actually, when we've gone back and looked at this, and we're involved in studies looking at tracking molecularly the different strains of RSV around the world, actually, it's like flu. It is spread via air flights around the world. So we actually take RSV with us, and then a new strain comes into a country and spreads within the community. And that was not something we had realised before the pandemic. So I think that's very interesting. And you can see that we've had these sort of atypical seasons that have occurred generally later before last year, but now we're getting back to a fairly typical pattern. And the increased numbers, I think, are increased use of testing on children in the emergency departments and to a lesser degree in general practice. So I think this is really important. And I think the increased adults' awareness of RSV is also revealing that true burden. And I think with data that we have recently been able to get linking hospitalisation data with and emergency department data with PathWest. In 2021, we found there were 520 admissions, 519 admissions in children under 12 months of age, and another 270 ED presentations. Now, that already tells me that we're not swatting everyone in emergency departments, because we should have about 2 to 3 times as many positive cultures in people presenting to ED. So that's clearly an underestimate. And this doesn't include the private pathology providers for hospitals such as Joondalup or Midland, which don't necessarily use PathWest. And in this data, actually a third of those admissions were in country areas. So those people who are either online or here today from the country will be familiar with RSV. And about 1 in 6 of them are in Aboriginal children, so much more than we would expect. So there's 2 to 3 times the risk for Aboriginal children. So clearly there's somebody that we would need to prevent the disease. And it's now a notifiable disease, and we know that about 50% of those 10,000 notifications in WA each year occur in children under 5 and predominantly in children under 12 months. So that's the picture for the burden of disease. Now, I was involved in studies 20 years ago with RSV live attenuated vaccines, but actually the story started 60 years ago. Following the development of the polio vaccine, they tried to develop a similar vaccine for RSV because they had just recently isolated the virus, and these studies in the NIH by these 2 gentlemen here actually found that children got sicker when they got vaccinated with a inactivated RSV vaccine made the same way as polio. And not only did they get sicker when they got RSV, there was no protection, and some children actually died. And so that enhanced disease following vaccination really stopped the development of RSV vaccines for almost 40 years. And it wasn't really until about 10 years ago that Barney Graham and Jason McClellan at the NIH actually worked out that we were making vaccines against the wrong form of the protein. And so RSV, like COVID, has a fusion protein, like the spike protein, that actually binds to the cell. And it changes when it binds to the cell. So it sort of flattens out and sort of makes a zipper so that it can infect the cells. And this is an example of the change in the shape. And actually, antibodies derived against this shape, which is its low energy, so it's natural conformation. If you just put it in, if you just sort of try and pull it out of the bacteria, the virus, it will revert to this shape. And we'd been making the vaccines with the wrong antigen. And so by stabilising this, we were able to make effective vaccines, and I'll give you some of the evidence of that. And in fact, that's why we had such effective vaccines for COVID, because we'd already solved this problem for RSV, and the problem was the same. So that's why they were so quickly able to make highly effective vaccines. Unfortunately, though, those studies that I was involved 20 years ago, we couldn't get a live attenuated vaccine that was get enough of an immune response, but not cause too much in the way of symptoms. And so to protect young babies under 6 months, we have to enhance passive antibody transfer to the babies. And there's 2 ways that we can do that. We can vaccinate their mothers, and we've had great successes with pertussis, influenza, tetanus in developing countries. And we know that mums are very motivated to actually get vaccinated for their babies. Or we can do immunisation with monoclonal antibodies. And as I said, we already had a monoclonal antibody that wasn't as effective as it might have been because it was mostly directed against that post-fusion protein. But it also means we've got a bit more flexibility about when we deliver it. So we can sort of approach it a bit more like a flu season. Or we might do a combination of both. And these are all things that are on the table. And a really important advance in the development of the monoclonal antibodies has been the ability to make it last for a whole RSV season. And I'll explain that in a bit later. There's a lot of people working on this. It's hard to make an effective vaccine. You can see all the discontinued and lines ruled out, and there's been a number of highly promising candidates that have got to phase 3 studies and then have not been able to progress. And you can see here that there's a large range of technologies which again actually put us in good stead for the pandemic, because these were actually, we were making mRNA vaccines for RSV before we started the pandemic. So that was another reason why we were able to progress so quickly. And you can see here that there are now a number of vaccines for the elderly that have been registered, a maternal vaccination in Europe and North America, and a new monoclonal antibody that we hope will be soon registered in Australia. So there's a lot of potential opportunities for RSV prevention that are going to be available. This is another way of looking at it. These are the three major target groups, so young infants, pregnant mums, and older adults. And unfortunately, the recombinant vectors, so this is like the Chadox vaccine that we had for COVID, have not been able to be progressed, partly because of the safety concerns that were raised by using those adenoviral vectors, and also for some of them not as good efficacy as you might have expected. But there are mRNA vaccines that will be available for RSV as well, and we will be involved in those trials as well. So about 8 years ago, we got involved in this study, which was the first maternal immunisation with RSV made by Novavax. And this was published a few years ago. And it was really the first time that it was shown to be safe in about for the 3,000 mothers who actually received the active vaccine, and were able to demonstrate efficacy against medically attended lower respiratory infection, bronchiolitis and pneumonia. And interestingly, also found that they decreased antibiotic prescription by about 13% in that first 3 months. So highlighting this sort of but using antibiotics to treat secondary infections after a viral illness. In fact, they didn't quite meet their endpoint, so they have discontinued production of this vaccine, but it really accelerated the other vaccines. And so there's been 2 maternal vaccines that have gone to phase 3 trial. Again, the GSK vaccine hasn't been able to progress because of an imbalance in preterm births in the active vaccine group that occurred only in low and middle income countries and predominantly in unvaccinated mums for COVID. So we think there's probably some interaction between, if you prevent RSV and you don't have that infection as a mother, you might be more vulnerable to COVID, which we know is associated with premature birth. And that wasn't seen in those countries where maternal vaccination or the adults had been vaccinated against COVID. However, the Matisse study was successful in over 7,000 mothers were vaccinated, and they were followed up to 6 months of age. And this is what that we are trying to do. So this dotted line is what is that we estimate is a protective neutralising titer from the work that's been done with the palivizumab monoclonal antibody. And you can see here that if you vaccinate a mum, this is what happens normally. So by a month, you start to get below that protective level, and that's when the peak of RSV infections occurs, whereas you can maintain them above that level for 6 months if you vaccinate the mothers with this protein vaccine. That's not dissimilar, I guess, to the pertussis vaccine we use in terms of its contents. And so this was recently published, and I won't go, there's a lot of data on this slide. You can see all the bar graphs are pretty similar in height, so there's not a lot of increased symptoms that occur in the mothers, but the majority, the only ones that sort of were notable were sort of some increase in muscle pain, particularly at the site of injection, and the pain at the injection site. All the maternal outcomes and neonatal outcomes, there was no difference. But we do see that if you have had the RSV vaccine, you're slightly more likely, not significantly, to test positive for COVID-19. So this sort of adds weight to that theory that what happened to the GSK vaccine. And there was no significant increase in preterm births, and this will be something we'll have to watch if we introduce this in the States. And it's now in this state, but it is being used in the US and has been licensed by the FDA, and we expect to be licensed in Australia next year. And this is the data that has driven that licensure, that you can see that you have high levels of efficacy against severe RSV infection, particularly being hospitalised, of up to 80%, 70% for hospitalisations, and almost 40% for any RSV infections, so upper respiratory infections as well. And this persists for 6 months, but then you start to get some waning by 12 months, which is what you would expect with a maternal vaccination strategy. But perhaps there is some ongoing benefit. And so I think timing of this will be very important. And one of the questions is whether you have a universal program throughout the year or whether you would only have it for those babies you expect to be born in the winter. So this is a summary. I think it probably has some additional benefits for the mothers in terms of breastfeeding and increasing antibodies that are in the breast milk. And importantly, there's no evidence of disease enhancement seen in any of these trials. So by using this pre-fusion construct of the proteins, they've been able to negate that risk. But what will be available sooner and is now being used widely in Europe is this next generation of monoclonal antibodies. And nirsevimab is the one that is licensed, and we expect to be licensed very shortly in Australia. And again, this is a specific monoclonal antibody against this binding part of the fusion protein here that is not present on the post-fusion protein. And by modifying the end of the monoclonal antibody, you can get an increasing recycle. That means instead of antibody levels waning after a month, they wane after 5 years. And there's a number of other monoclonal antibodies that are in phase 3 studies, such as this one made by Merck. But I just wanted to highlight one of the issues with monoclonal antibodies, and this is what's happened with COVID, is that you can get critical mutations in viruses at the active site of that monoclonal antibody. And this happened with subtavimab, that it happened to coincide with a mutation exactly where it was going to bind, and so it was no longer effective. So this is why we need to be able to track the molecular changes in this virus as we go, although it's not as frequent as you see with COVID. There are some changes. And this was the pivotal phase 3 study that we were involved in, about 3,000 infants, randomised in a 2-to-1 ratio, and these are the results. And again, very similar to the maternal immunisation. Over 5 months rather than 6 months, you see high levels of efficacy against all low respiratory infections where you have to see a doctor, hospitalisation, and almost 80% for very severe where you're requiring oxygen or high flow nasal cannulas or IV hydration. So again, very consistent with high quality antibodies protecting infants against those outcomes. And importantly, preterm infants, in a study we did prior to that was published about a few years ago, we again saw very high levels. And I just wanted to point out that this is the rate of the number of those infants that attended to their GP, so almost 10%. So that's that 1 in 10 that we talk about that they were able to reduce significantly. So very common. And in fact, when you looked at all the hospitalisations for any respiratory illness, so not just RSV, it was 40%. And this tells you that about half these kids getting admitted to hospital in any winter is due to RSV. So this is really useful when we're thinking about it. And for the GPs, such as Alan in the audience, we'll decrease by a quarter those children presenting with their premature or term infants. And this is recent data that's come out of Europe from a real-world efficacy study where they randomised 8,000 infants at a variety of ages, so just before the RSV season, so what we would think about doing, and again, mostly under 6 months, but some who were over 6 months, and mostly term infants. And so what did they found? The efficacy against hospitalisation was actually even greater in this cohort. So almost 83% of hospitalisations were prevented. They didn't look at those other seeing a GP or ED presentations, although that data will become available. The study is ongoing. And in this context, so this was the last Northern European winter, this represented 58% reduction in all hospitalisations. So I think we can actually prevent about half the kids getting admitted to hospital if we used it in a similar manner where we had a universal program. So as a paediatrician, this would be fantastic for the Children's Hospital and those peripheral hospitals that all get full of their paediatric beds with RSV each winter. This is the sort of number needed to treat. So about 10, almost 11, just under 11 infants immunised would prevent them seeing to need a doctor, and about 50 number to treat. And we would estimate this will be something in WA if we got 80% coverage of over 2,000 GP and ED presentations, about 450 admissions, allowing for some of that underreporting that occurs. And so this might be the way we could use it, is that you vaccinate infants who are born before the RSV season just immediately prior, so March, April, May, usually during a routine visit, probably their routine vaccination visits, and it's certainly been given with these other vaccines and routinely in Europe and North America currently. And for those babies during the RSV season, we could either give it in maternity hospitals, but I think probably more likely it will be easier to implement if GPs are giving it to babies once they get discharged from hospital. But either of those would work. So maybe we could use it for with maternal vaccination as well. So I think these are the important messages, that this is highly effective, high uptake in Europe and North America. So they've actually run out of monoclonal antibody in many of these countries. In Spain, I think they had something like 80% uptake in their infant cohort within the first few weeks. But we need to monitor effectiveness and safety and variant escape. And there's also another monoclonal antibody coming, which will hopefully decrease the price. Just quickly mentioning RSV vaccines for older adults. This is a problem probably unrecognised. Mostly people who have comorbid conditions, particularly those severe cardiorespiratory conditions. And if they do get it and are hospitalised, they have a reasonably high mortality rate. And like flu, you get long-term complications following hospitalisation with RSV if you're an older adult. And I won't go through this, just to say that like in the maternal vaccination programs, we have high levels of efficacy against these sort of different markers of severity, over 80% maybe, or even up to 90%, but no evidence against hospitalisation because it's not as common as flu. I won't go through the paediatric data. There are vaccines coming in the next few years. So just in summary, I think hopefully you would agree that we have safe and effective mechanisms for preventing RSV disease. WA could have a universal monoclonal antibody immunisation program next year. I hope the minister chooses to fund it, and we have other vaccines to prevent it. Just to acknowledge all the people I work with who do some great work. And if you're interested in RSV, there's the RSV conference. I'm on the board of ResVinet that's in India next year, where you'll hear a lot more about the effectiveness of it. But I'm happy to answer questions, and keeping to the Game of Thrones theme, I'm still learning. So thank you.
Thanks. Is that on? Yeah. Thanks, Peter. I just was wondering what you think could be driving the increased risk of COVID infection in the RSV vaccinated mothers.
Yeah, so I think we know that there's some what's called trained immunity, so that when you get one virus, you get a non-specific enhanced interferon response actually in the mucosal surfaces, and that protects you for a period of time against other viruses. We've seen it with flu, and we've seen these sort of interesting during the H1N1 pandemic, where if you'd had the seasonal flu vaccine, you seem to be a bit more likely to get the pandemic strain. And we think that's probably because you're not getting a general viral boost by having it. But that's a hypothesis, hasn't been proven, and the analysis of that particular study is coming. So we will find, but I think that's most likely. But clearly it's a safety issue we'll have to monitor closely. And I think WA is very well placed to do that.
Is there any other questions?
You have to. Thanks, Peter. That was a really great talk. I was just wondering, in terms of, I guess, the safety concerns about the maternal vaccines versus the monoclonal antibody. I mean, in your opinion, as a paediatrician, do you think that the monoclonal antibody will be more accepted by people? I guess, is that an argument to go down that route, or what's your thoughts on that?
Yeah, that's a great question. I think it actually varies on where you are in the world. So apparently French people are not keen on vaccination generally, but they have had very high uptake of monoclonal immunisation. So they see that as a safer option. I think in Australia we actually have very good maternal vaccination uptake, but we always struggle a little bit, and I think that's we just don't quite have those processes yet. Getting obstetricians on board with vaccination is a challenge, and I think that it's difficult. So I think our difficulty is seasonal program versus universal maternal immunisation. What's going to be easiest? I think my personal opinion is that actually a monoclonal program is probably going to be more efficient at preventing RSV. And I think that's what we saw in that study, in the Harmony study in Europe, that they got very high levels of protection and efficacy. So that would be my guess, but it may be that, and this would be a question for the GPs online or in the audience, can we deliver it with our routine immunisations? And I think this will be easier than flu, because flu was, is really, they were getting vaccinated when they were either at 6 months or 12 months, and trying to get them in between time was difficult. difficult during that winter period. And so that's why I think we've struggled. And then we had the safety aspects of it. But yeah, that's a really important question. I think the other thing is, do parents actually know about this? Clearly they do in Europe, and, they talk about the triple pandemic, with flu, COVID and RSV. I think in Australia, we've still got work to do. And, I acknowledge Catherine Hughes is doing some fantastic work in this area, but I think it's on everyone that we need to start talking about this now. And we don't have to worry about it in Children's Hospital. In our studies, it's all nurses and doctors who are coming in with their babies or pregnant mums, because they know exactly what RSV is about. But the general community, not a lot out there, I think. So that's something we have to work out.
Thanks, Peter, for a great talk. Just wondered with the RSV and with the side effect with COVID, is there protection from RSV to COVID? And do you envisage one day to have like a combination vaccine with COVID and flu?
Yeah, so the interaction with COVID and RSV that I was talking about is a non-specific one. So I think it's with any viral illness. So it could be flu and COVID or flu and RSV. There is work looking at combination vaccines. So RSV and flu, or RSV and COVID, or, COVID, flu and RSV, and that's sort of the mRNA vaccines. I think it's going to be difficult, though, because we have to change the flu vaccine much more often than we do the RSV, and COVID's sort of somewhere in between. So I think that will be difficult from the regulator's point of view. There probably will be combination vaccines of RSV and something called human metapneumovirus, which is RSV's baby cousin that causes a bit of disease but not as much. And those trials in children will start soon, and I think that might be something for babies over 6 months. But I think probably at this stage it'll be RSV alone, but it'll be interesting to see where that goes. Okay, I'm happy to chat during the coffee break or the lunchtime if you've got any other questions. Thank you.